or interferon alpha, etc. And when the targeted therapy introduced, two important trials introduced in late 2018 and that time, 17, and that one was Carmina trial and another was Sartime. That challenged the conventional belief of that cytoreductive nephrectomy definitely has a role in metastatic RCC. And two big questions was faced. One is whether cytoreductive nephrectomy has any role. If there is a role, then whether it is upfront cytoreductive nephrectomy or it should be done deferred after targeted therapy or a session of targeted therapy or few cycles. So the Carmina basically nephrectomy vis-a-vis sunitinib, nephrectomy followed by sunitinib and sunitinib alone. It was a non-inferiority trial, and it found that the sunitinib alone is not inferior as compared to nephrectomy followed by sunitinib, though there are lots of limitation. Subsequently, if you see this patient here, the majority of the patient was either intermediate risk group or poor risk group. Subsequently, they have updated the data and they said if in some selected group of intermediate risk model patients with a risk factor of 1, maybe little bit, they may be benefited with cytoreductive nephrectomy. However, with a risk factor 2, may not be benefited. Sartime trial basically looked into what should be the what should be the timing for cytoreductive nephrectomy in this group of patient, and they have done upfront nephrectomy followed by sunitinib and sunitinib followed by nephrectomy, so which is known as a deferred nephrectomy. So, and they found with the delayed or deferred nephrectomy, twofold increase in survival and decreased complication. So, in view of these two trials, the take-home message was either no upfront nephrectomy in majority of the patient, and if you are at all doing nephrectomy, then probably deferred is better. So probably IO added more confusion, and as we know that after this checkmate 214, keynote 426 and Javelin 101, these trials has introduced, and they have with a level 1 evidence that either combination of IO and targeted therapy is better than targeted therapy alone. So with this vision, we probably understand that probably cytoreductive nephrectomy has no role with IO because IO is more effective systemic therapy as compared to targeted therapy. However, the data is not clear. And whatever data we have is a very weak evidences. But if I'll go through the evidences with the role of cytoreductive nephrectomy with interleukin. So with immunotherapy. So the first evidence we have is there was a published article in 2020 from America, and they have analyzed the data of the National Cancer Database, and they found that IO before cytoreductive nephrectomy has resulted in lower P stage, grade and tumor size, and definitely there is a advantage if you see this. Sorry. If we this survival curve that cytoreductive nephrectomy and IO is having definite advantage as compared to IO alone. But there was no subgroup analysis whether this patient had good risk, poor risk or intermediate risk. And this was I think most relevant study I could find out regarding the timing of cytoreductive nephrectomy in this current era. And if you see, this title begin with upfront cytoreductive nephrectomy. Interestingly, the 70% of this patient who had upfront cytoreductive nephrectomy are intermediate risk group and 30% are poor risk group. So we cannot ignore the data. It was not a good risk group and as a good risk group patient. And they found there is definitely improved overall survival with upfront cytoreductive nephrectomy. So these are the forest plot of all the literature available. I took from this meta-analysis, and we can see the cytoreductive nephrectomy definitely has role in immunotherapy era, and it favors cytoreductive nephrectomy plus IO as compared to IO alone. So now I'll go through the guidelines, but most of these guidelines is based on the targeted era literature. So do not perform cytoreductive nephrectomy in MSKCC poor risk. This is based on the Carmina trial only. Intermediate risk group, they should be, if asymptomatic patient, then patient deferred nephrectomy is better than upfront nephrectomy. But if, this is a very important, if patient does not require systemic therapy, then perform upfront nephrectomy. So ultimately, if patient is not a very suitable candidate, or if you think that systemic therapy is not required now and patient is a good risk or maybe intermediate risk in an era of immunotherapy, probably they can be benefited by upfront nephrectomy.
Half a minute left.
NCCN guidelines, if you see, they again said that potentially surgical resectable patient consider cytoreductive nephrectomy in select group, or poor risk group only systemic therapy. So it's very difficult to say something very strongly, but the optimal use and timing of cytoreductive nephrectomy in immunotherapy era is more confusing than probably what we had in targeted therapy. Yes, for some, that may be good risk patient, upfront cytoreductive nephrectomy. Maybe for some, maybe of some intermediate risk group may be benefited by upfront or deferred cytoreductive nephrectomy. And poor risk group, mostly no for some, but the result of immunotherapy is probably much better than targeted therapy. So many patients who looks not operable, not surgical candidate, but after giving systemic therapy with IO plus target therapy, they may be benefited by deferred cytoreductive nephrectomy. So what, probably we were better positioned before this current era, but now we don't know most of the thing, but what we know that cytoreductive nephrectomy likely to improve survival in good risk and intermediate risk group. Upfront may be offered in at least good risk. Deferred is probably better than upfront in intermediate risk, and some maybe some group of poor risk patient. Thank you.
Quick 1 or 2 questions. We have got 2.5 minutes.
Okay, Dr. Sanjay, Anand here.
There's
Yeah, there's also whatever, I commend you for an extraordinary presentation. There's also the best robust evidence that we have for upfront cytoreductive nephrectomy in the, in the IO era comes from an abstract from the IMDC database that was presented at GU ASCO 2020. So 4,700 odd patients where they've substratified and looked at, what patients got benefit with upfront cytoreductive nephrectomy, whether in the cytokine era or the IO era. And they found out that, by every analysis possible, univariate, multivariate, propensity matched and everything else, patients who got upfront nephrectomy derived the same benefit whether they got upfront cytokines or whether they got upfront immunotherapy. So the quantum of benefit did not differ. So most patients did get benefit. I think that's the best evidence that we have as of date.
So I was supposed to talk the role of upfront nephrectomy, but this is the last 2022, the European Urology published data. That was also based on 6,000 patients. Probably that is the latest data we have. Thank you.
Now, metastatic RCC, now, the landscape has changed.
Right, sir. Of course.
Oligometastatic and polymetastatic.
Right.
So, oligometastatic, there is definitive role of RT and oligometastatictomy as well.
Right. If you can resect, the guidelines say that if you can resect the metastatic burden, maybe 1, 2 or whatever, then definitely you should go for cytoreductive
No,
nephrectomy.
here there is more robust evidence there from SPRT. If you go back, my radiation oncologist can elaborate about role of SBRT and oligometastatic RCC. That part is there, good evidence is there. Now, management of the local disease, again, we have to follow the IMDC guideline at the moment, IMDC, yeah.
IMDC is not guiding you anything. It's just giving you a risk model. That's it.
Yeah. So, but till we have other things, once this IO therapy era, all those mature data comes.
So basically in future, there are 2 prospective randomized control trial is ongoing. One is PROB trial, and there is SWOG, I forgot the number. So they are basically cytoreductive nephrectomy plus IO versus IO only, vis-a-vis. Yeah. So probably when the data is mature, then you will get a definitive answer.
Yeah, to the radiation. Oh yeah, thank you very much. Yeah.
Thank you.
Thank you, Dr. Sanjoy Sureka.
Thanks.
I would like to now invite Dr. Gargi Mulye, who is an assistant professor in the Department of Radiation Oncology at Tata Memorial Center, Mumbai. She will talk on post-RC adjuvant RT treatment, when and how. Over to you, Dr. Gargi. You've got 7 minutes for presentation and 3 minutes for discussion. Thank you.
Hello. So, post-cystectomy adjuvant RT, why and how? So, as we all know, outcomes after cystectomy are poor. And this is persistent even in the era of NACT. Like we can see that in the SWOG 8710, the median survival post-cystectomy was 77 months. And once relapse has occurred, the survival is really poor. So around at 24 months, less than 20% patients were alive. So we all know that RT is a local treatment, and so if we do give radiotherapy, it will improve local control. But is local control really a problem after surgery? So yes, it is. From these different groups across the world, we can see that local regional recurrence is seen in around 30 to 40% patients post-cystectomy. And most of these patients have high-risk features, that is advanced T-stage, node positivity, margin positivity, and poor lymph node yield. So the same thing has been studied in our group of patients from this institute, where we saw that in the highest risk group of patients, around 35% had local regional failure. And another useful thing we found from this study was that around 25% patients had a recurrence in the common iliac region, which was not routinely irradiated. Apart from that, in spite of margin negativity, a significant number of patients had recurrences in the cystectomy bed itself. So, so we know local regional recurrence happens, but is adjuvant RT effective? So yes, it is. So in this phase 2 randomized trial where there was adjuvant sandwich chemotherapy plus radiotherapy versus chemotherapy alone, we see that there was significant improvement in local regional control and DFS. And so that is the added benefit of radiotherapy. But is improving local control enough? So yes, we do have some answers from that. So in this analysis of 268 patients who were enrolled in the SWOG trial, we can see in the lowermost part of the table that in patients who did have a local recurrence, only 10% was surviving at 5 years. So, so far we have seen that RT improves local and disease-free survival, but we don't have prospective data regarding overall survival, but in this retrospective study from the NCTB database, we know that patients with advanced T-stage margin positivity and node positivity, they had significant improvement in overall survival with the addition of adjuvant radiotherapy. And this is also endorsed by NCCN. So how must we do radiotherapy? Because there have been a large amount of concern with the toxicity of radiotherapy in the post-op settings with surgeons and as well as in the radiation community. So as we can see from these trials conducted in the 1990s, early 2000s, that there were high rates of toxicity at post-op RT, especially intestinal obstruction. And these rates were unacceptable. And that is why there was hesitancy in giving RT. But what we must know that this is how radiotherapy looked then. There were big blobs of big doses. And so we must see what is the toxicity with our current modalities. So the earlier phase 2 trial that was considering sandwich chemotherapy and radiotherapy, that used 3D CRT for treatment. And as we can see, grade 3 toxicities were seen in only 5 patients with RT and chemotherapy. And there were no reported grade 3 or more obstructive uropathy. Again, this is the second one is a phase 2 trial where the primary endpoint was seeing late toxicity. And as we can see here, in the GI toxicity, only 4 patients out of 72 had significant GI toxicity. And in terms of GU toxicity, interestingly, they have studied outcomes with 17 patients who had a neobladder. And as we can see here, even with a neobladder, RT was quite safe. So we now know that IMRT helps, but how much does it help? So we already have randomized data from other sites in the pelvis, such as the prostate and post-op cervix, that IMRT significantly improves toxicity. So we can safely extrapolate this to the bladder. We now have standardized contouring or target delineation guidelines for bladder radiotherapy, the recent most which were published last year. So as we can see here, this is the target delineation for the pelvic nodes as well as the cystectomy bed. And what we have recently started doing at our institute is we inject diluted contrast into the ileal conduit and delineate it along with the targets and consider it as a normal tissue. And so while planning, as we can see in the middle picture, we avoid large doses of radiation going to the conduit. And we hope that this will significantly reduce toxicity, especially obstructive uropathy. So we have ongoing trials. There are 3 randomized trials going on across the world, one of which is our very own BART, headed by Dr. Vedang Murthy. And hopefully we will have results in the next few years, which will establish radiotherapy as the standard of care after cystectomy. So in summary, who will benefit with adjuvant radiotherapy? Patients with advanced T-stage node or positive margins, and patients who have had an inadequate nodal dissection. How should RT be given? So IMRT should be the standard, and it is useful to treat both the cystectomy bed as well as the pelvic lymph nodes in all patients, irrespective of margin status. And a useful practice would be to limit dose to the ileal conduit and the small bowel. We will hopefully have results in the next few years from well-conducted randomized trials, which will establish adjuvant radiotherapy as the